Welcome back, everyone, to the ResearchWorks podcast here at EACD and the IAACD 2025 in Heidelberg. And with me now, I have the one and only Professor Ann-Cristin Eliasson. Welcome to the podcast.
Thank you.
It's so lovely to have you here. I remember last year we were trying to get you onto the podcast and we just couldn't coordinate the times. And this time I was much more organized and sent you an email way ahead of time. Anki, whenever people say your name, the first thing that comes to my mind is Max and AHA.
Okay.
Because I feel like you've been so influential in that space. Can you tell us a little bit about the Max and the AHA and how it's just transformed the way we look at things right now?
I've been around for quite a long time, And in the beginning of 2000, everything was about gross motor function.
It was, wasn't it?
And you have the GMFCS. And I met Peter Rosenbaum.
Yes.
And I said to him, why has you not developed anything for hand function? It's very important to be able to use your hands. That's what you do every time.
True.
Every day.
Yeah.
And he said, fine, do it yourself. And I said, okay, if you help me, because I wanted it to be in the same kind of construct as the GMFCS.
It's so understandable already. Yeah.
So that was the early start of quite a long process before we got the idea, handle object. Today it seems so obvious that is what you should classify.
Yeah.
But at that time, it was not the common word as was used in pediatrics. So when we have got that concept, then it was more easier to go on. So that was the start. And
that is brilliant. So over 20 years ago, and I, you can see the work that's been done, now presenting at all of the conferences. When you have a classification system, we can better communicate with each other. And I see it everywhere now. Yeah. It's the basis, isn't it?
It absolutely filled the gap.
Yeah, it was a big gap too.
Yeah, it was a big gap.
And what about the AHA?
So I also think it filled the gap. And that was also in the same time period, actually. And we started... When I did my PhD a long time ago, I did it on experimental research of hand function. So hand function was natural for me. And at that time we were thinking, is it actually possible to make intervention of hand function?
Yeah.
Nothing. It was just nothing in the field. And then suddenly this idea of constraint-induced movement therapy comes up. And it was for adults, and there was a lot of discussion. You could do it for children or not, and a lot of debate around those things. And then there was a colleague of me coming to say, I wanted to try. And so we said, okay, we try. And then we said, we have no assessment. Yeah. How should you be able to evaluate something? You don't know what to do in the training. You don't know how to evaluate it. That was the early start.
Yeah.
So we said, okay, what we can do is to film the children. And we try to say, okay, we're working on hand function. We need to have some assessment to sort of capture something they're doing. So we pulled together some small objects and we were filming it. And then we were looking at that films and we say, oh, this seems to be something, because when we compare the films before and after the first early phases of intervention, we could see differences.
Right.
And then when we have been working on that for a while and said, okay, people see the differences. What is they actually seeing? And then they were saying, okay, we need to try to sort of go into these films and really try to categorize what we actually were seeing.
Perfect.
So the intervention was driving the development of the assessment.
That's amazing.
And that's the same thing, for the high.
Yeah, okay.
Because we started in the way that we have older children for the sim training.
Sure.
We started actually with teenager because, at that time it was hard to try to... People thought we were crazy. Actually, they did.
Did they really?
They told me in the conferences, you can't do this.
Wow.
So things have changed a lot
over
the years.
Absolutely. But it takes people like you to push the boundaries. Well, yeah, it does, isn't it? Because at the end of the day, it's doing something different.
Yeah.
It's out of the norm.
Yeah.
But now look at it.
Yeah.
It is the norm.
Yeah.
Yeah.
It is the norm, actually.
Yeah.
So when we try to push it to use for younger children, we said again, we don't have any assessment.
It is very true. I think outcome measures. I remember when I was an early researcher and I would always think, developing outcome measures. Oh, that's not fun.
Yeah.
But when you're doing an intervention and you want to be able to demonstrate or to determine if there's any effect whatsoever, you rely on outcome measures, good, valid outcome measures.
And I mean, it's stupid actually to try to develop assessment because it's an ongoing story. You never get finished. And luckily, my colleague Lena Kronlinde has been so eager on this kind of work, you know. So she has done a lot of these tricky, picky things to get these psychometric properties to work.
It's a big field. You're absolutely right. It's not as simple as going, I'm going to develop an outcome measure pre or post. It has to be psychometrically sound if it's going to be useful. So thank you, Anki, for driving and doing that work, because without that, we wouldn't be looking at some of the outcomes, for example, in early intervention. And I know that you were part of the pre-conference workshops at Melbourne, and I've had the great opportunity to speak with a lot of the speakers, and the outcome measures are the ones you spoke about. But you presented on something a little bit different, of the real passion of supporting families in more remote communities. Can you tell me a little bit more about your presentation?
As I also said in the presentation, in the society in Sweden, it works very well to use parents as trainees provider.
Okay.
I mean, we did it in the beginning of 2000, as early as that.
Wow. Okay.
And again, people said, you can't do it. You can't make parents to therapists. And I think what we have been trying very hard is not making them to therapists, but making them good parents to understand how to help their child to develop.
Sure,
more to support them to be the one who know what is good for their child. So actually, I don't think we try to turn them to therapists, but we help them to develop as parents.
Right.
But you can, of course, discuss that. People have different opinions on that. But it has been possible to do this in Sweden in a good way, I always say.
Right.
Because it works in the society. Parents are expected to take in part.
Yeah.
And I know it's different in different countries.
Yeah.
So for us, it was quite easy, sort of, to use the parents. And in the beginning, we went home to the families and sort of supporting them at home. But home visit... Tell me how long time it takes.
Yeah, that's right. The travel,
it's half a day for each visit.
Yeah, wow. Yeah,
and it's costly.
Yes.
So we were thinking we should be, because there's less resources around.
Yeah.
They all the time get less and less.
Yeah.
And I wanted really to implement this in the clinic.
Yes.
Because I wanted it not to be research. So there was some early sort of development of digital tools in 1915.
Okay.
When we started this, actually.
Wow.
It was before the pandemic.
Wow. Okay.
So we said we should try to see if we can use this platform to insert some information about the symptom, have these video meetings and things like that. And it was quite tricky with the technology in the beginning.
Yeah, it wasn't quite there yet. COVID definitely helped, didn't it?
The pandemic was fantastic from this perspective.
Yeah,
you know?
yeah. Technology came a long way.
So actually it was, for me, it was a way to implement it, to make it to a remote training.
Okay.
Because I understood that there will never, ever be resources enough to continue to do home visits.
Sure.
It will be too expensive.
Yeah, you could see it already. Yeah, and it's happening now. Yeah, you're seeing it. Yep.
And then we did the first study where we have a control group with massage. And that was where we have the training at home. And then we continue with this remote training. And then I could compared the results from the group who have had home visits and meeting the therapist in person with the group who only gets remote training.
Right.
And then my results was exactly the same.
Interesting.
And that give me strength to say that this works.
Yeah.
You don't need to go home. You can coach them on a remote way.
Wow.
But it is, of course, a big difference for the therapist. I usually said location matter.
Yeah.
Because in the hospital, the parents usually look what's going on.
Yes.
The therapists do the work.
Do it. Yep.
When you go home, you can still show.
Yeah.
But you probably also are sort of motivated to have the parents to train because you know that they need to do this when you have left.
Yes.
So you do a lot of demonstration, you are model, you ask the family to practice and you see what's going on. Then when you come to the remote coaching, you have to put words on everything you have in your hands.
Right. That takes a lot of skill.
That's a skill.
Yep. Yep.
And that was very fascinating because we have just done an interview with a therapist who has been doing the remote training. We try to understand what is the difficulties, what is the good thing, how do they feel about it. And
what did they say?
One of the therapists said, I feel like a sport commentator.
A sports commentator. That's a really great way to describe it.
Because she has to use a lot of explanation of what's going on, what they actually were doing.
In real time.
In real time.
Successful or not successful, but described in a different kind of way. Wow. That's a really interesting point. So that's a nice way to describe coaching, I suppose, because we're hearing the word coaching being used a lot in this conference.
Because after, when she have done these comments, she has to discuss how could you do instead? What was good? What was bad? What happened if you do it this way?
Right.
But she has to put words on all those things as you usually have in your hands.
Where we often internalize our dialogue. We're not describing what we're doing. That's a great point.
So I think it's part of the skills that they have to develop.
Sure. Yeah.
But of course it means that they have to be experienced to be able to do this. So to put newly educated people in a remote setting, that's very tricky.
Sure.
You need to have it in your hands before you can put it in your mouth.
So does that mean, I guess what that could look like for a hospital or an organization is a training program? Is that how that could work? Because you're right. If you haven't ever done it before, to then commentate, like I would never dare to commentate on snowboarding. I think you need to do that. You wouldn't be able to do it right. What would your recommendation be there for that transition, I suppose?
I mean, you have to work in the clinic with the children before you can take over the role as a coach.
That's beautiful. Yeah. It's not
you
just a given.
need
You
to
can't
know
just be a coach.
a lot about early intervention and how children develops.
That's good advice.
Yeah. And I also think both the parents in the interview with parents as well as the therapist, they highlight the importance of a relationship.
Yes.
So we recommend when you have a remote training that you have to meet the family in person at least once to build this strong relationship, or because the therapist, the parent says in some of our interviews, it was so important that they understand when things not going well. Yeah. That they also could see all these small things as happening as no one else is seeing than the therapist.
Yeah, that's true.
And that they sort of are aware about the life situation. Because this is such a vulnerable situation in daily life. So you can't just coach and predict that they should do exactly what you say. You have to be listening. Yes. You have to have this interactive
You have to have
feeling.
that relationship. And what you described there is so profound, because I think sometimes it can be misinterpreted when we say you can do things online for telehealth, you need to coach, but there's preparation for all of that. It's just like now that we've met in person, if we have a Zoom chat with each other,
No.
it is so much easier because we have a bit of a relationship. We've seen each other in real life. Rather than if it was always online, our relationship is just an online. It's not quite three-dimensional.
No.
But I love that
it's
you...
a huge difference.
Yes, it is absolutely true.
Mm-hmm.
So what does this mean then for early intervention and early detection? Because that's such a pivotal point that we want to intervene as early as possible. But there may be those restrictions in home visits and support. This must have very significant impact for that phase.
If I got your question right, I think parents to the children, vulnerable children, they have been in the neonatal unit, many of them. They have been sick.
Yeah.
They have been in the hospital hundreds of times.
Yeah.
They try to avoid coming to the hospital. And I think we should sort of accept that.
Yeah.
And we shouldn't bring them in more than necessary.
Yeah.
When we now have developed the screening version of HI, we developed it in a way that parents can collect the data for us at home.
Wow.
But it doesn't mean that we don't talk to them.
Yeah, that's right. Okay.
But when we come up with that tool and we have just tested it, and in that study we could see that most of the parents actually said, we prefer to do this assessment at home because we could collect the data. It's a small 5 minutes video recordings where they play with the child.
Right, okay.
And they can do that when the child is alert and awake and in a good mood.
Yeah.
When they come to the hospital,
often
it might be some different story.
Yeah.
Some parents noted also, but we missed the discussion. So I think you can do this, but you should still continue to talk to them.
Yeah.
But you don't need to spend time on collecting data as they can do much better by themselves at home.
That's wonderful. It takes the pressure off. Because you're right. Sometimes they come into clinic and they haven't slept well and the parents are just apologizing when they shouldn't need to apologize for that. And it's unpredictable in a different setting. Yeah.
And if you know them well, you can do this by phone or by a Zoom meeting or something like that. Even if you know the family.
Yeah.
But I mean, everything has to do with your relationship to the family. But you should try to decrease the burdens of going to the hospital for many follow-up visits, I think.
Yeah, that's absolutely wonderful.
But still keep the connection to the families.
Yeah, that's absolutely true because that relationship is a very strong relationship when you first meet them within the hospital because you're there all the time.
Yeah.
And then I think it'll be very difficult to keep changing to different group of therapists. And sometimes you have to because it's different age groups. But we want to try to cut down as much of that as much as possible, don't we? It's very stressful. Anki, what would you say would be your biggest piece of advice? I feel like you're full of wisdom. Your biggest piece of advice, maybe let's start with for parents. For parents listening, what would you say to them based on all your experience so far?
I want them to feel secure in and trust their ability to cope with their child, to knowing what is best for the child.
Yeah.
Because if they by the treatment have got self-confidence, competence, they probably feel better. Many of the parents have said that doing something is lower the shoulders. It decreases the stress.
Yeah.
And I think this is so important. I mean, this period of life
that's right.
is so sensitive for everything. So you have sort of to give them courage.
Yeah.
And then if you ask me, you can do a bit different things to achieve this.
Yeah.
It's not only one way to go.
That's right.
There is a lot of early intervention treatment these days, who seems good.
Yes.
So choose what is suitable.
I like that. Because you're right. Not everyone is the same. They'll have their different situations. Some will prefer to go to a clinic. Some will much prefer to have it at home. but let's make sure we match that up so that it's right.
Yes.
We don't have to be so regimented, isn't it?
And you know, when you come to the hemiplegic children, has always been a debate, should it be constraint or should it be bimanual training? And I said, it doesn't really matter.
Yeah. Well, that's what the results are showing, isn't it? What would your advice then be for therapists? Therapists working in this field, in early intervention and, with a caseload. What would your advice be for them based on your experience?
Many people, therapists, ask me, how should I be able to start?
Yeah.
I haven't done this before. And there is not so much courses you can take. And then I usually say, but you have to try.
Just do it.
You have to make a commitment with the parents, and you have to look at what you're doing. You have to look if you see if there is some changes, and don't be so scared to start.
Yes.
But you be very sensitive and look for the results.
Yes.
That you're feeling that you're doing the right things.
That's great advice. Anki, what an absolute privilege it is to speak with you. And I can just feel wisdom coming from your side to my side of the table. And there's so much to learn from you. But you come at something with absolute compassion, generosity, and an absolute care for the children and the families that we work with. So thank you for the work you've done in the field. I'm someone that we have not met yet, but I read your work. And to be able to meet the person behind all of this, I can see why everyone looks to you. So thank you so much for joining us on the podcast today.
Thank you.
Thank you. To all of our listeners, I hope that inspired you as much as it did for me. There's a lot of take-homes there, both if you're a parent or if you're a clinician trying to do the best in this field. There is great advice from Anki here. So hope you enjoyed that. We'll talk to you all again really soon. Bye.
Bye.